Hello and welcome to Health and Wellbeing Live, sharing knowledge and experience from Nottingham City. Keeping people informed about the issues, people, services, supporting health and wellbeing in and around Nottingham City. This is a relaxed podcast style production. We're pitching this at an interested and informed audience, so there's going to be little dumbing down. We're going to try and have an in-depth conversation lasting about 20 to 30 minutes about an issue that really matters to health and wellbeing in Nottingham. It's open to anyone to listen, so please dip in and have a listen. Today we're talking to Rich Brady. Rich is the Programme Director at Nottingham City Place-Based Partnership, and I'm Andy Foster. I'm a GP. I'm a Director at GPA, which is the local GP Federation, and I work at Place along with Rich as a Deputy Inequalities Lead. So those are my sort of declarations of interest. But hello, Rich. Welcome.
Morning, Andy. Some good credentials you've got there.
Rich, thanks for joining us and telling us a bit more about the Place-Based Partnership. And I'm going to dive straight in and ask the big question. What is the Place-Based Partnership, or PBP, as we call it within the system?
That's a good one to start with. So what is the PBP? Well, it's a non-statutory partnership of health, local government and voluntary sector organisations. There's four in our integrated care system, but we're going to be talking about the one in the city today, and that's the one that you and I work in. So it's a non-statutory partnership, which basically means there's not a requirement to have it, although there's lots of encouragement to have partnerships like this, particularly in the NHS. Because it's non-statutory, as I said, there's no requirement. So that means it's essentially a partnership of the willing. So people have to feel that there's going to be value in coming together as a partnership. And we've had this PBP in place in Nottingham City. It used to be called the Integrated Care Partnership. We've had it in place for about 4 years, and so you have leaders from some of the big health and care organisations in the city, such as the council, the NHS Trust, the GP Federation, and voluntary sector organisations.
Yeah, thanks, Rich. You mentioned it's not a statutory organisation. What would be some examples of things that are statutory? Because I think a lot of people don't understand the difference between the two.
Yeah, so statutory organisations, I guess, are organisations that are there, been put there in legislation, so such as a city council or an NHS trust or an integrated care board. So they have a function by law, I guess. So they have duties that they have to carry out and responsibilities that they have. So that's always an interesting thing for us to consider in the place-based partnership as well, because a lot of the partners are made up of statutory organisations. And they have things that they have to do. So we have to consider those things when we're thinking about partnership priorities.
Yeah, thanks. And I guess I'm seeing another example of a non-statutory organisation that we kind of work with, and that's the NCGP Federation, for example. And it doesn't mean that there isn't important work that's done by those organisations, vital work. It's just, I guess, that they're not mandated to exist by government legislation. Yeah, so that's helpful, Rich.
Right.
Before we dive further in, I was just wondering if we could learn a little bit more about yourself and your background and the journey you've taken to becoming Programme Director of the Place-Based Partnership.
Yeah, sure. I mean, I've been doing this role for about the last 4 years now. It'll be 4 years next week, actually, I think, when I started this. But yeah, I started off many moons ago working within children's services, within children's social care, so sort of working with children and young people in care homes, which was a great start to my career, and I loved it. But I was always quite curious about what happened to children and young people after they left residential care, and so I moved into various policy roles in voluntary sector organisations. So particularly leading on children in care policy for a voluntary sector organisation, and then learning more about how the policy landscape worked through other roles for other voluntary sector organisations, and that was mainly in London. And after that, then I moved into the world of regulation, particularly in health and care regulation. So with the Care Quality Commission, so thinking of working specifically on things like mental health policy. But where my experience really overlaps with this is I took part in a place sort of review program, or it was called a system review program then. So we went all over the country looking at how partnerships are working together to support the needs of older people. And there was particular focus around supporting older people who are discharged from hospital, but that was the focus. But you get much more into how organisations work together, and the responsibilities that they have. So I had this amazing opportunity to be able to do this, and I went all over the country over a couple of years looking at how things worked, very much from a kind of health lens, but also then looking at it from a local government side, and how systems were making the best use of voluntary sector organisations. I got a bit more in-depth experience then, working for the local government association, then, so having a bit more of a in-depth understanding of local government, before then coming into this role. So I guess I've got experience working, within the voluntary sector, local government, and health. So yeah, trying to draw on that experience as much as possible to work out how organisations from those different sectors can come together and work together most effectively.
Yeah, and it's actually, I've never really had this conversation with you before, Rich, but I can see how actually you've got experience from within a number of those partners that actually make up the place-based partnership. So it must be really useful to know, how they tick, how they work on the inside, and what drives their behaviour and their agendas. Is that something that you find useful in your role?
I think what you've just said there, what drives behaviour, I think is a really important thing, because whether or not you're a statutory organisation or not, you're there for a purpose, and that is usually to provide the best service or care or support, whatever it is, to people. And that's ultimately what everybody has in common in the place-based partnership. We work with the same people. And so your question was about how you sort of draw on that experience, and I think one of the biggest things that we have to do as a partnership is understand and appreciate where each other come from. There are drivers for behaviours, whether or not those are the priorities that we've determined, the way in which organisations are funded, whether they're governed, whether they're statutory or not. And it's about, if we're able to have a better understanding of where each individual organisation comes from, we'll have a better idea then of what we can do collectively together, and actually have a bit more of an appreciation of why someone might be behaving in a particular way, or why someone might think something is a priority, and why someone might think something isn't a priority, for instance. So it's really important to have that understanding of how each other tick, as you put it, Andy, in order to make the partnership really sing.
Yeah, that's really interesting. So I guess different organisations they'll have different motivations, and they'll have different obligations and requirements, which will make them behave in different ways. Just made me think, because you've seen inside a few different types of organisations in the partnership. I've only really seen inside health, and a lot of people watching might have just seen from within their own organisation. What are some of the differences or similarities, say, between NHS organisations and local government, or anything else that you've noticed in terms of differences between the partners?
Well, I guess so. So if we do the difference between NHS and local government, so the NHS is sort of centrally mandated through NHS England, and is centrally ultimately accountable to the Secretary of State, and instructions is what we're putting it, but the way in which the NHS functions is sort of centrally determined, and also there's heavy sort of regulation and oversight of health from a sort of central point of view. However, from local government, for instance, while there is support through the Department for Levelling Up, Housing and Communities, actually a lot of what is prioritised is determined locally. So through locally elected politicians, working alongside officers, and they are elected, based on manifestos and of what they said they will be able to achieve when they become in control of the council, for instance. So the drivers for, so there are many different drivers, I guess, particularly within local government, for how organisations might behave, or the priorities that they might wish to focus on. So it's not always centrally mandated, perhaps in the way in which it is within the NHS. So there's lots of different considerations you need to give, and while you might have an individual working within one of those organisations who thinks it's a really good thing to do, actually there's things outside of their control, or there might be priorities of others that actually lead them to to do things that they might not ordinarily do if they were in control, if you see what I mean. So it's quite different, and that's where I talk about you have to really understand what it's like for people working within different organizations, and what the cultures that then sets within the individual organizations, to work out how you get the best culture within your partnership.
Gosh, it's beginning to sound like a very tricky role that you've got there, Rich, making all of these parts of the system work together in harmony. Rich, I was wondering, where does the place-based partnership sit within the system? Because we'll all be aware of, there's GP surgeries, there's hospital trusts, there are primary care networks now. We have ICSs that we maybe used to think of as ICBs, and we used to think of those as CCGs. Where is place-based partnership within all of that structure?
Yeah, okay. So I would say, I would call sort of integrated care systems, place-based partnerships, and then primary care networks a sort of partnership architecture is maybe the way I'd sort of talk about it. So integrated care system, so thinking from Nottinghamshire, covers a sort of broad population of about 1.2 million people. And what we do is we have, so you have organisations that span the whole of that geography. So Nottinghamshire Healthcare Trust, for instance, covers the whole entire geography of that area. But then you have other organisations that cover just like the city area. So, you have like the council, for instance, Nottingham City GP Alliance, for instance, will cover the city. But then you'll also have smaller organisations that might just cover much smaller patches, neighbourhoods, etc. So the thing is you kind of need to have the different infrastructure in place because of how the organisations are stretched across those different geographies. What the value, I think, of having it at place, particularly for us in the city, is that we do have a number of organisations that work around a geography in the city. So as a place-based partnership, we share the same boundary as the Nottingham City Council and then the Nottingham City Health and Wellbeing Board as well. And that brings together a number of different organisations, such as the Council, Nottingham City Care Partnership, GP Alliance, Nottingham Community Voluntary Service. We do have some of the NHS providers which cover a wider geography than just the city. However, what it does is, by having that focus on a place-based partnership, and while these boundaries might seem artificial to anybody living within the area, actually it makes it easier sometimes for those organisations to be able to orientate their resource around need, and again, I don't think that's something that necessarily the citizens, the population, really need to be that bothered about. Really, I don't think it's that important to people. It is important to the people working in it, because we have to make sense of it from the way in which our organisations are structured. But it shouldn't. I don't think it really matters to the population what the partnership infrastructure is. So by bringing all of that together, we're then able to say, right, okay, so we're all focused on this same population. What can we do within what we already do within our organisations? How do we work together to make sure that we're providing the most joined up offer to people who live in the city? And then just finally, on the primary care network side of things, which you've had involvement within primary care networks, Andy, we have 8 of those within Nottingham City, and ultimately I see it as the place-based partnerships responsibility to almost empower that sort of more local neighbourhood working by using the infrastructure of those organisations across the city to be able to support those more local teams to be able to meet the needs of the people and the patients that they see within their areas.
Good. That makes a lot of sense. That's helped me understand things a bit better, but it is complicated, isn't it? Rich, I was just wondering, so that's where the place-based partnership sits within the system. I was wondering just a little bit more about what's happening at the top, or kind of the higher levels of the place-based partnership. Who's there? What are the roles? What does it mean to be program director, and where does that sit with the chair and the other roles at the top? Are you able to tell me a bit more about that?
Yeah, sure. So first of all, I say in my role as program director, I almost sort of coordinate the activity of the partnership, and I support the leaders of the membership organisations in coming to decisions about where we want to focus. So so we have an executive team. So the chief executive of Nottingham City Council is the lead of the partnership and sort of chairs our executive team meetings, and you have chief executives from those organisations or executive director level, so quite senior level representatives from each of the 9 partner organisations we have within the place-based partnership. And I guess I see it as my role as helping those leaders to be able to work out, where do we, amongst all of the stuff, all of the services, all of the duties, the responsibilities each of those organisations have, where do we come together to almost knit between them? So we provide lots of individual services, but sometimes people can receive support from 4 or 5 different organisations, and they're seeing all these different name badges and people, but there's not making any sense of it. I see it as the place-based partnerships role to, again, not necessarily enable someone to actually understand what it does, but for us to do that behind the scenes, to make sure that the organisations, the people who are working for those organisations, are able to work together around the needs of people, then to make sure that they get the most sort of seamless care, support, or service, or whatever it is. So that's ultimately what I think the responsibility is of the place-based partnership. And then where we've come along, and in 4 years that we've been doing this partnership activity, is we've worked out that we need to have a focus on particular cohorts of the population. So that's people with similar types of need, for instance, and mainly those who interact with all of our different organisations. If you experience multiple disadvantage, you can have a mental health need, you might have a housing need, you might interact with the criminal justice system, substance use, you might experience domestic abuse. The way in which we're set up as services can often mean that we're there for singular issues. So you go somewhere for your housing needs, somewhere for your mental health needs, somewhere for your substance use, etc. Now, if you're a person who experiences 3 of those things, which is what we've determined as multiple disadvantage, getting access to one can be hard enough, but then getting access to multiple is really, really difficult. And actually wanting to stay engaged and getting pushed from pillar to, well, feeling like you're being pushed from pillar to post, saying you go there for that, you go there for that, it's not going to help people who are in that sort of level of need. So what we need to do as a place-based partnership is do that work for them, is do that work around them, so that when you get that, when I'm looking for housing support, I'm also able to work out where I get the mental health support. I'm not having to do that myself. I've got someone else to do it for me. And so ultimately, that's what we should be doing. We should be making it easier for people.
We've mentioned a few times like the needs of the people, and I guess that leads into a pretty logical question, really. What do you see as the current challenges in terms of health and well-being for people in Nottingham City? Or what does the place-based partnership see as the challenges?
Well, yeah, I mean, at Nottingham's there's a high complexity of need across a range of different areas. I guess the fact that people are living a lot longer is a good thing, but in Nottingham, whilst people are living longer, people are also living longer in poor health. So within Nottingham, particularly for women living in certain areas of Nottingham, you can expect to have some of the sort of poorest healthy life expectancy anywhere in the country. So you're among the top, which is not a good thing. And what I mean by healthy life expectancy is where you reach a point in life where you're perhaps living with a long-term condition that's quite serious that you have to manage over the rest of your life. And so there are some areas in Nottingham where you can be living a third of your life with a long-term condition, and that's not a good thing for people. So there are real challenges, and there are also challenges for people around deprivation as well. There's a lot of what we might determine the wider determinants of health, sort of access to good housing, to employment, and things like that. There are sort of multitude of issues where people are unable to get access to those sorts of things, which then compound their health to become even worse. So I'm painting a pretty pretty stark picture here, but that is the reality of what we're faced with, I guess, within Nottingham. So what we have to do is we have to be considerate of all of those things and not just think it's about providing health services to people for when they get ill. It's about taking a more sort of public health approach to be able to make sure that people have the tools and resources that they need where they live to be able to feel like they've got good well-being, or feel that they've got access to things that can help them manage their health more easily. And if they don't, that we then work out how best to provide that support to people. Nottingham is obviously a hugely diverse city as well, and actually sometimes the services that we might set up through the NHS or through local government, whatever it is, they might not feel as accessible to people from different communities. And that's important that we listen to that and adapt and be flexible to it, not just say, well, this is the service, and if you it's yours to access. If people are not going to access it if they don't believe in it and if they don't trust it. And I think that's the big thing that we've been working on in the last couple of years over the partnership is trying to understand how you build that trust between people in communities who are fairly skeptical actually about the services that are provided and won't access them because they don't believe in them and they don't trust them. That isn't for us just to say, well, okay, well, that's just how it is. It's for us to say, right, how do we build that trust with people in communities so that we can provide something that makes them feel that they're able to engage with it and better support themselves, really.
Yeah, I would say that is a really big challenge, reaching out to underserved communities. Have you learned anything within the place-based partnership about what seems to work, or what sort of approaches are you taking?
So I think ultimately the important thing is to listen, and I think it's also listen, but also acknowledge that it's there. And I think that's the thing is, I guess within these roles sometimes you could be quite removed to what happens, is what's happening within services. And it's really important that you're not, and it's really important that you understand what's happening, what's going on. And I think one of the biggest assets that we've got in Nottingham is our community and voluntary sector. Got a really vibrant and diverse community voluntary sector who work with people who have different types of need or perhaps don't access services. I always think about the voluntary sector, that these organisations exist because people's needs aren't being met elsewhere. And ultimately, that's what we've got to think about is how do we, if we want to be flexible to the needs of different people and different communities, how do we work through those voluntary sector organisations that are able to be much more flexible than the large, and sometimes quite bureaucratic organisations that we have in the NHS and in local government? How do we work through those much more flexible, agile organisations in the voluntary sector to better support people? It's not always about the NHS or the local government providing absolutely everything. It's about how do we empower those other organisations, and how do we sort of empower, but also devolve a bit of responsibility or delegate some responsibility to them to be able to do it and support them. And we're only going to create better partnerships through doing that.
Yeah, absolutely. Patient empowerment, really, really important. Community empowerment. Absolutely hear you there, Rich. So I'm just wondering, we began to talk about, the challenges, and I guess those must shape the priorities that place-based partnership has. I don't know if you're able to talk a little bit about the current priorities of the place-based partnership.
Sure. So as I said earlier, we've determined that the best way that we can operate as a partnership is by corralling around the needs of cohorts of the population, but also taking a sort of public health approach. So the Nottingham City Place-Based Partnership is responsible for overseeing the joint health and wellbeing strategy. And the joint health and wellbeing strategy is, first of all, it's a joint thing between local government and ICB, so Nottingham City Council and the Nottinghamshire Integrated Care Board. So I use that word again, statutory. It's something that we have to have. And there are 4 priorities within that. I've talked about severe multiple disadvantage already, but there are 3 others. So one that we call eating and moving for good health, which hopefully does exactly what it sort of says on the tin. How do we support people to eat and move better? One, looking at smoking and tobacco control. So Nottingham still has one of the highest rates of smokers anywhere in the country, and there are particular areas. In fact, I think in your neck of the woods, Andy, where there are particularly high levels of smokers, and it's about how do we support people who want to quit, but also how do we work with wider agencies like enforcement agencies and the police to look at tobacco control measures where there might be illegal tobacco in circulation, for instance. So we have a massive alliance across Nottingham and Nottinghamshire, actually, which is bringing together these key partners to look at how you support people to stop smoking, but also stop that supply of illegal illicit tobacco. And then finally, I also talked about the wider determinants of health, and we know that income and employment and a good income are really important enablers of that. And in Nottingham, there are there's high levels of income deprivation. So in the strategy this time, we've called that out and said, right, we really need to focus on actually improving people's financial well-being and their resilience to absorb financial shocks, which is so apparent in the current climate. So those are four priorities that we are all delivered in partnership. So you have program leads for each of those, but they're all supported by the program team. So you've got people from all the different place-based partnership organisations who work on those programs and they deliver together. In addition to that, though, we've got some other ones as well. So there's two I particularly focus on. So there's one which is focused on race, health and equalities. So as I noted earlier, first of all, there are huge disparities and inequalities, and you can map that to ethnicity in Nottingham City. And as I said before, you need to be flexible around different communities and cultures. And so this is a way of us thinking about how are we more flexible around people's ethnicity and cultures. And then finally, we have a mental health program as well, which looks at, mental health is amongst all of this, and it's about how are we supporting people to better look after their mental health. So the race, health and equalities program and the mental health program are almost they're not in the strategy, in the joint health and wellbeing strategy, but they're part of the place-based partnership, and they underpin all of the work they do. So when we have the SMD, the severe multiple disadvantage program, the smoking, financial wellbeing, eating, moving for good health, we make sure that those partnerships are considering the impact on race, health inequalities and mental health within all of them. And then finally, we have another program as well, which is looking at supporting children and young people leaving the care system. We know that being a young person or having care experience is a fairly good indicator for people who might experience multiple disadvantage in adulthood. So what we're trying to do is work as a partnership to best support children and young people in the care system to prevent them from experiencing multiple disadvantage in adult life. So those are the sort of population health focused programs that we've got, but there's loads of other stuff that happens as well, and we have these sort of similar projects working within PCNs within primary care networks, which I won't go into now. But the final bit I just want to say about the sort of priorities for the PVP is through the executive team, we also have a series of what we call enabler programs, and this is about creating the conditions for integration to happen more easily. So I think we acknowledge that people work in partnership often despite the conditions that are in place rather than because of them. And so what the executive team have done is agreed 6 enabler programs looking at things like adding social value, like looking at how we better use data within our partnerships, bringing our workforces together, community empowerment and others, to say how do we then support all those other programs I talked about earlier. Those will work much better if we get the building blocks and the foundations in place to make integration happen more easily.
One of my other questions, Rich, was going to be sort of how does the place-based partnership kind of operationalize that? How do they deliver? What do they do? But I think you've answered that actually within those answers. Really, was there anything else you wanted to say about kind of what the place-based partnership is doing day to day to deliver? Or I think you might have covered it, but just give me that opportunity.
I guess the final bit that I probably talk about is what I've said at the beginning, which is about empowering people who work in services, who see people, who provide services, care and support to people, to be able to do their job more easily and to be able to work in partnership more easily. And that the work we're doing around creating integrated neighbourhood teams and integrated models of support for us as a wider partnership, that's the really, really important thing. So that's the thing we're really trying to accelerate now as a partnership. We've sort of proven the concept that working in partnership is a good thing and with lots of benefits to doing it. But what we have to do is knit together those services that each of us provide better, so that it is less chaotic for people receiving the care, but B, it's also less chaotic and difficult for staff as well, for people working within those organisations. We should make sure that our structures are not so rigid, so that we can empower people to work together more easily. And if we can do that, people will get better care and support, and I think people will feel better about the jobs that they do and the care that they receive.
Good. So it looks like we're heading towards ending on a positive note, which is really, really good. What do you see as the opportunities in Nottingham going forward? So we sort of talked about the past, the present, but going forward, where are the opportunities in health and wellbeing in Nottingham?
So, I mean, I think I've probably covered this in what I'd say about really working out how we make best use of the voluntary sector. I think that's a huge opportunity, and I'm not wanting to put a downer on this, Andy, but what we do need to think about as a place-based partnership is the fact that there are pressures all over the place at the moment, both operationally and financially. And what we have to do, and what I do see as an opportunity, is to look at those things that those organisations have to do and work out how you best marry those up. Like we've been meeting together as a place-based partnership for the last 4 years now. We've got some fantastic relationships between those organisations, between the leaders of those organisations and between people working at all levels, which I don't think we would have had before. So the opportunity now is to now take it to the next level.
That's great. You talked about the voluntary sector quite a lot. I was just wondering about commercial partners and whether there's sort of much buy-in from commercial partners. There's a lot of big businesses based in Nottingham. You may have been having conversations with them. Is there any opportunities in that area?
Yeah, so I think it's probably an area we don't make use of as much enough, I guess. And again, it's about, I guess for those organisations, it's got to be about what they're looking to achieve as well, and working out where you've got the alignment there. And I'll give an example of where we have worked with a sort of big sort of private organisation is within the multiple disadvantage work. We were put in touch with Tesco, the supermarket chain, who I had a discussion with one of the directors there, who was talking about the number of people who are sort of rough sleeping in and around in and around their stores. And what we did as a result of that is we created a training program for their staff, so the store directors and all the store managers, to be able to help them to provide better sort of psychologically informed environments is the term that we use, but more sort of welcoming or inclusive environments for people, and actually supporting them to understand that homelessness is one thing, but actually if you are homeless, you are most likely to be experiencing multiple disadvantage as well. So it's about training the staff to understand why people might be behaving in a certain type of way when they are in or around those stores, and what that's led to is an ambition for Tesco now to roll this training out much wider than Nottingham and Nottinghamshire. So there are opportunities here, but you have to be able to I guess to work out where their priorities lie in order to make sure they align with ours. But it's something we probably haven't focused on enough. And something we could definitely do more on. But I guess that's an example of where we have had some success.
Yeah, that's sort of really astute observation about needing to understand their their objectives. But I have heard that story from other places actually about Tesco taking up the pie and tick training, psychologically informed environment, trauma informed care training that was developed for GP practices and and other organizations within the health system. So that's a really, really warm story actually, and a good place to bring things to a close, I think. Last question, Rich. We're having a number of people on these podcasts in this series, and we're asking everybody, what would you like people to do next after they've listened to this podcast? If they were to do one or possibly two things, after listening to this podcast, what would you ask them to do?
Well, the first thing I'd say is, welcome people to get involved as much as possible. We've got our website, which which has got much more detail about the work that we do. So first of all, go and visit that and find out a little bit more. But actually, reach out and work out, if what you're doing chimes with what I've been talking about, or those priorities that we've got as a place-based partnership, then we want more and more people to become involved. Like success breeds success within all of this, and partnerships breed partnerships as well. And within some of these areas, we've got these huge partnerships that are really touching across multiple areas of work. And that's because we've got such wide input from a variety of different individuals and different roles in different organizations. So it's more trying to, I guess I want to encourage people to get involved, and obviously to contact me if if you want to understand about where you could fit in. But also, just even if we're not focusing on anything that you think is really important, so there might be something where you think there's real opportunities to be able to work in partnership here, let's hear about it, because I think we should always be open to thinking about working differently together. And I think that the executive team would be really pleased to hear about those opportunities. So please put forward your opportunities, and what we'll do is empower you or empower others to be able to take them forward.
That's great. Thanks so much for spending time with us all today, Rich. Hopefully people have learned more about the PPP, what it does, how it functions. There are some other episodes within this series, Health and Wellbeing Live in Nottingham. We've had a good interview with Hugh Porter, who's the retiring chair of Place-Based Partnership. So the link will be available, I think, somewhere around where you're looking or listening to this, and there'll be other interesting podcasts and little mini stories from Nottingham in the series. So thanks everybody for spending time with us and listening, and thank you very much, Rich, for joining us today. Thank you.
Thanks, Andy.